Morning, morning everyone. I hope you're well. Welcome back, Monday, 10 o'clock. Last week we looked at the parasympathetic nervous system. Morning, Martin. Pop you in there. Just finishing off the autonomic nervous system and its relationship with the thoracic spine. And this week, going to have a look at just a little bit of pathology stuff to do with the thoracics, and then we'll move on to the cervical spine. So we're finishing the spine. So we've spent quite some time going through the lumbars and the sacrum and working our way up and all the visceral organs and everything that are in that area as well. So yeah, this will be our last bit of the spine. So before we get going, let's have a look at this. So we've got this relates to some abdominal organs as well as ones that are in the thoracic cavity, but it's a good idea to have a bit of a refresher anyway. So we've talked about this a little bit with especially liver problems. So if we have a look here, we've got liver and gallbladder located in this region of the abdomen underneath the rib cage. So hence why we're like using it as part of this thoracic pathology. But if you have a look at where it refers to, we can get pain up in the shoulder and the neck, okay, and just below the shoulder blade. So if there is a problem with the liver, and there'll be other signs and symptoms to do with that as well. So maybe lifestyle issues, maybe family history. You might see changes in the color of their skin, changes in their nails, history of heavy drinking, that kind of thing. Then, which you pick up in your subjective history. Then you may suspect that somebody's neck and shoulder pain after doing a musculoskeletal exam is, and if it comes back negative, then it may be something else, and the liver is something that you may want to consider to get them referred for to just have a check. So yeah, it's again we've kind of I think we covered it when we looked at the diaphragm. So we looked at something called Kerr's sign. So when there's an irritation of the diaphragm, the nerves that innervate the diaphragm come from your neck, and so messages are sent from the diaphragm saying something's going on up to the neck, which are then passed on to the central nervous system. But there's a shared sensory pathway at that part of the neck, and it's shared with the shoulder. So the brain in its wisdom, body in its wisdom, thinks can't be coming from the diaphragm, it must be coming from your shoulder. So that is why we experience these shoulder symptoms with liver problems. Same with the heart. You know, we don't have a direct link with the heart and this part of your arm, but you get pain down your arm if you're having potentially if you've got a heart problem. So and it's the irritation to the pericardium, so the outer layer of the heart, the connective tissue section that we looked at a few weeks ago, and that's again, it shares an innervation with the sensory nerves that supply down the arm. So again, there's some like confusion in that region, and can't be coming from your heart, must be coming down your arm. So that's why we get these symptoms that are referred from heart conditions. So classic heart attack is arm and jaw symptoms, and also it could be mid thoracic pain. Okay, so again, you might have someone coming in with pain in between your shoulder blades, and it could be their stomach, or if it's a little bit higher, kind of like those upper rhomboid areas, maybe it's not the rhomboids, maybe it's something to do with their heart, and you need to delve a little bit deeper into their subjective history to see whether you've missed something. Okay, and you need to get them referred. Okay. It can be both, Martin. Yeah, it's usually the left, but it can be both. I've seen it. I've seen a couple of papers where they describe it down the right arm as well as the left. Yeah, good question. Morning, Tris. You had a hell of a journey yesterday, mate. Oh, sorry about that. So we had a course yesterday at the academy in Ludlow, and the rain gods were raining down all around us, and quite a few floods, either stopping people coming to the course or stopping people getting back home again. So I'm glad you made it back home in the end, mate. Is there anything else on there? That was it really. Okay, so visceral referral from these organs that are contained within the thoracic cavity can present as musculoskeletal problems. So you basically need to make sure that you do a thorough subjective history. So these are some other things that you might want to think about. So obviously myocardial infarction or angina. Could be giving you symptoms down the arm or up into the jaw, as we were saying. An aortic aneurysm is a little bit lower. Well, it can be higher or lower. You can have an abdominal aortic aneurysm, or you can have an aortic aneurysm that is just kind of like on the arch of the aorta. So basically, it's like where there's turbulence in the artery, builds up pressure, and then the artery then just starts to swell, and it's like liken it to trying to blow up a balloon, and you get to that point where you've filled it with air, and then you've got to give it a really big blow to get that first bit to go, and that's basically what happens when you have this aneurysm. So there's a build up of pressure, and then all of a sudden the arterial walls will just balloon. Okay, and that can be quite devastating. So it can be there for quite some time with people not knowing about it. If it's in the abdomen, then quite often you can have associated lower back pain, but you may have pains in between the shoulder blades or anywhere around the chest wall. And again, they kind of mimic musculoskeletal pain, but when you do all your MSK tests, there's nothing symptomatic. So it may be a visceral problem. To do with the lungs, there may be pneumonia, emphysema, pleurisy, COPD as an umbrella term for those kind of conditions. And then it could be a renal issue, so a kidney problem, pyelonephritis, and that will give you flank pain, so around the ribs. Okay, so if we go back to that picture, I don't think it's on here. Yeah, so around this area here, and and the lower back. Okay, so quite common because of the urethra as well, connecting to the kidneys. You can have widespread referral as well as localized around the ribs. Okay, so kidneys can be an issue as well. Gastrointestinal issues, stomach ulcers, gallbladder, pancreatitis, cancers, all of those kind of things could potentially refer lower back area, abdomen, down into the pelvis and the groin. And again, it's nothing to do with the musculoskeletal. It's a systemic problem. And then again, in the thoracic region, could be breast cancer. And obviously there may be localized symptoms, but they can refer as well, potentially down the arms or to the back. So yeah, there's quite pain is not a very good way of working out where a problem is. We just know that there is one, and so that's why we do our clinical reasoning, and we look at everything broadly. We need to know about all of the different signs and symptoms, about all the visceral organs and the musculoskeletal tests. And then we do our musculoskeletal tests, and if they're positive, then that's great, because that's something that we can deal with. And if they're not, then it's something that we need to refer. Okay, and they need further testing. So this is just to give you a bit of an idea. The abdomen region is split into these areas. So we've got internal organs in the main cavities of the body, especially those in the abdomen. That's what the viscera is. And we've got the right hypochondriac area, which is where your liver will be, hypogastric in the center, so center top, and then left hypochondriac. We've got right lateral, umbilical, however you want to pronounce it, left lateral, and then your right inguinal, however you want to pronounce it, epigastric, and then left inguinal. So it's useful to know what organs are in these quadrants, okay? Because if someone is coming in with right inguinal discomfort, then it could be something to do with the ascending colon. It could be something to do with the appendix. Could be something to do with the valve that connects the small intestine to the large intestine. Could be something to do with the hip. Could be something to do with the glutes. And this is one of the things that amuses me when we you get those questions. Oh, I've got this patient with X and pain in X region. What do you think it is? And you're like, oh my God, it could be so many different things. You've given me no information. I don't know about any of their history. I don't know what tests you've done. I don't know what tests you know how to do. And it's just never ending. Yeah. So if you just analyze just that region there, there's probably about 20 differentials that it could be. And then we haven't even looked at referred pain, because remember, referral from the kidneys can come down into this region as well. So it's really, really difficult to give that kind of advice online because you just haven't examined somebody and you don't know what tests have been done. So it's, I think if you're asking the question, and this might sound a bit harsh, but if you're having to ask the question, then really you should be referring that person to someone who can do a more thorough exam. And it's not being horrible, it's just realizing the limits of your capabilities. Really, I would do exactly the same if there was somebody in who I wasn't sure what was going on. Then I'd refer them to someone else. It's being professional, I think. Cool. Okay, and then last thing, so this is specifically for the thoracic spine, and it's a condition called Sherman's. It usually affects teenage boys. So Sherman kyphosis, also known as Sherman disease, juvenile kyphosis, or juvenile discogenic disease. It's a condition of hyperkyphosis. So you can see this extreme kyphotic position of the thoracics. That involves the vertebral bodies and discs of the spine identified by anterior wedging. So there's a squashing of the front of the vertebra where on X-ray you'll be able to see that. Of greater than or equal to 5 degrees in 3 or more adjacent vertebral bodies. So this is how it's categorized, diagnosed. The thoracic spine is most commonly involved, although involvement can include the thoracolumbar region as well, which looks the case with this chap here. Most commonly, diagnosis is made in adolescents between 12 and 17. So if you've got a juvenile that's coming into clinic and they've got an extreme kyphosis, then they may have Sherman's. So it's worth referring them to their GP to get checked out. Sherman's disease is the most common cause of kyphotic deformity in adolescents. A hereditary component is understood to contribute to the condition, although the mode of transmission is still unclear, so that it may or may not be part of family history. And basically, you will see a hyperkyphosis. There'll be reduced extension because of that wedging, so you can't extend the thoracic spine very well, and also reduced rotation because of the collapsing of the thoracics, the approximation then of the rib cage. So it's really difficult then to rotate through that thoracic spine. So if you're doing some normal like thoracic tests and seeing what kind of range they've got, and it's reduced, and they've got this what looks like the kind of beginnings of a kyphosis that looks a bit bigger than usual, then they may have Sherman's. Pain in the affected hyperkyphotic region may also be the cause of the initial evaluation, just because it's symptomatic. So you can do something called a occipital to wall test in clinic. So you can get someone with their back against the wall and see if they can get their head to touch the wall with their thoracics touching as well. People with Sherman's will find that quite difficult, and there'll be a very obvious and steep thoracic curvature. And then referral for something called the Cobb's angle test should be sought by the GP. That's what they do. You can have operations for it. It depends how much it's affecting your function, to be honest. Some people live with it quite happily. Some people don't, and so they'll try to correct the Cobb angle using surgery. Okay, so yeah, it depends. Good question. Perfect. So that was it. Just a brief kind of overview of some common things to look out for with thoracic pathology. Right, let's have a look at this one. Here we go. So we're going to have a look at the cervical spine and the bones and joints of the cervicals, starting at the top. So those top two joints, the atlas and axis, and then we'll work our way down. And then once we've done the bones and joints, we'll start to add on the layers of connective tissue, exactly like we usually do. So cervical spine then is made up of 7 vertebrae, and they are irregular in their shape. So they've got pointy bits sticking out to the side bits, similar kind of structure to the thoracics and the lumbars, but there are some specific things in the thoracics that don't occur anywhere else in the body. Okay, so these are categorized as irregular bones, basically. So our functions are to support the skull. So your top vertebra will support the skull itself. It helps as a shock absorber for the brain. So there's a curvature in the cervical spine, which is a lordotic curvature usually, and that provide, if you have a bang on the head or something, there's a bit of flexibility in the neck, so that it's not such a massive juddering impact. Yeah, so we've got this force distribution. Obviously, protection for your vertebral spinal cord, but also protection for the blood vessels to your brain. Okay, so there are specific little gaps in the side of these vertebrae that are very, very important for the protection of the blood supply that gets like right into the center of your brain. Okay, and we'll have a look at that when we layer on the blood vessels as well. We've got force transference as usual with bones, especially this many bones in a region. We've got that distribution of force. Muscle and ligamentous attachments with all these little sticky out bits here, all these little prominences. This is where muscles will attach to, and they'll obviously develop over time. And as the muscles are being worked, they pull on the bone, and then the bone lays down more bone. So each vertebra, each neck is unique to you. Okay, so if you start to take up an activity that you've never done before, and it involves a lot of neck movements, then your neck will adapt over time to those movements. And then if you stop doing that activity, then it will adapt to not doing those movements anymore. Okay, so yeah, everybody is different. We've got physiological movements. So what that means is we've got movements that you can do on your own. Okay, so flexion, extension, side bend. Then my side bend's really poor at the moment, and then rotation as well. Okay, so all of that comes from the neck, and the amount of rotation and flexion, extension, side bend will differ depending on the part of the spine, and we'll have a look at that as we go through. Some things to note is this vertebra at the top here, this C1, it doesn't have a spinous process, which is one of these. Yeah, so this is the bit that sticks out at the back that you can feel. So if you have a feel of your own neck, you can feel some bony prominences, and C1 doesn't have one. Okay, so if you come directly off the skull, there's a space. Okay, you push in there, and there's like a soft tissue load of mass, basically. Okay, load of muscles in there. And then the first vertebra, cervical spinous process you'll be able to feel is C2. Okay, the most prominent one is this one down here, which is C7. So again, if you have a feel all the way down your neck and you feel that really big vertebra just at the kind of top of your upper back, bottom of your neck, that's C7. Okay, so those that one there and that one there are quite they're obvious to be able to distinguish between all the others. So these are the upper cervicals, so C1 and C2. These are called the atlas and the axis. Okay, and we'll talk about the reasons for the names in a sec. So just underneath here, can you see that kind of shadowing underneath, so where it's been like made a bit more transparent? That there is this vertebra here. Okay, so this vertebra, C1, will sit on this one, C2. Yeah, and if you can see, we've got that there. This is the odontoid peg, or sometimes called the dens. Okay, so that there. So you've got this peg that sticks up, and then the top vertebra fits around it, so it can rotate. Okay, so the atlas, which is this one here, if you remember from the Greek gods, the atlas holds up the world. Yeah, well, the atlas in this case holds up your skull. So your skull will attach into here. Okay, so these are the superior, so up above, articular facets, so joining faces, okay, for the occipital condyles, and the occiput is on the skull. All right, and we'll get to that when we move a little bit higher up. We'll revisit this area again, but the base of your skull is called the occiput, and that sits on these. Okay, so that it sits right onto that atlas, and then the atlas then sits on the peg, so the dens, so that it can rotate, and that's where most of your rotation in your neck comes from, is from this C1, C2. Okay, a couple of other things to note. We've got the transverse processes, which we've seen before. So when we looked at the thoracic spine, when we've looked at the lumbar spine, we've seen these side sticky out bits of bone. But in these cervicals, they've got a hole in them. Okay, you can see that there. So this is called the transverse foramen. And that hole there is where the cervical spine differs from anywhere else, because that hole is where your blood vessel will come through to go to your brain. Okay, there's other blood vessels as well, but this one's particularly well protected because it travels up either side of your neck, and then it creates like a bit of a question mark shape as it comes up around this bit. In fact, you might be able to see here. So can you see that one there and then there? So they're quite narrow, yeah, but this one is really wide. So because that wider one sits on top of the narrow one, the blood vessel, as it comes up through, it has to come out to the side and then back around again. So it looks like a question mark. Okay, so when you have a look at it in a second, you'll be able to see it. What the reason for that is, if it was straight up and it was just in a straight line, if you try to rotate your head with a very straight artery, you're going to pull that artery with every rotation that you do. So there's a bit of slack on the artery as it kinks around to allow the head to rotate. Okay, so it's a pretty good design. We've got a posterior tubercle here. Okay, so there is a little bit of a lump on the back of this C1, the atlas, but nothing like this. Okay, so it's not a spinous process that you can feel. It's just a little lump, and because of all the musculature around that area, you can't really feel it. Okay, it depends on how slim someone is. We've got an anterior tubercle at the front, so that'll be poking into the back of your throat, basically. Okay, so you won't be able to palpate that at all. We've got this arch here, this anterior arch, and it's that arch and this little facet joint here that connects with this. Okay, and then this is all held in place, this peg, by ligaments, and we'll have a look at the ligaments next week when we get to that. Cool. Right, let's have a look at some videos of this, just so you can get an idea of what we've just seen. Okay, so going to have a look at the atlas and axis. Okay, so here we are. So there's your facet joints. There's your little transverse processes. We've got posterior arch here, so it's orientated differently from the picture we've just seen. We've got these lateral masses where the articular surfaces sit on. That's where your spinal cord will go through, and that's where the odontoid peg will be. So you'll see that in a second, see the relationship between the two. So your skull will sit on here, on these joins here, and then those holes there, that's where your blood supply will come through, and that's where you'll attach to C2. Here we go. So here's C2. There's the joint surfaces. There's the peg. Okay, so that's the odontoid peg, odontoid process, or the dens. So that it's called a few different names. Here's your transverse foramen. So that's where the blood vessels will come through. There's your facet joint, and another little facet joint underneath as well, because obviously the joints are stacked on top of each other. And then we'll see in a sec when they're both together. There we go. Okay, so there's the peg, and there's the motion available. Yeah, so if you imagine your skull on the top of that, able to rotate around that peg. There is a ligament that holds it in place. We'll talk about that when we get to those. I think one of the key points for this, and especially this odontoid process, this odontoid peg, is it's one of the reasons we're really worried if someone has a neck injury in rugby or something like that, or fallen off a bike or car accident or whatever it is, and why immediately you'll be put in a collar, because if that peg becomes fractured, then there's nothing like holding your head in place. Yeah, so if you move your head, then it can glide those upper vertebrae, and because of the proximity to the spinal cord, it can cause widespread paralysis. Yeah, so one of the things that we were teaching a first aid course the other week, and we were talking about neck injuries, and if they're suspected neck injury, you keep it dead still, and then you wait for the ambulance to come. Okay, and the reason why we do that is just in case there's an injury to something like that. Yeah, so and we can't tell. Yeah, you won't be able to tell from just looking at them. They may have signs and symptoms. So symptoms being pins and needles, tingling in the fingers and the legs. If that's the case, then we're definitely suspecting some kind of neural compromise. So we definitely need to maintain the position of that head. Okay, so if you're dealing with like pitch side stuff, it's not usually something that would walk into a clinic after a couple of days. You've been playing rugby on the weekend and your neck's a bit sore, and then you come in and you're kind of suspecting this. It's usually on the pitch. Okay, however, saying that, you could still suspect this even if it is a few days afterwards, because some people might have a fracture. They've kind of their necks all stiffened up, and they just don't feel right, and and the head doesn't feel stable. And if you're getting that kind of feedback from someone in a subjective history, then I'd send them off to A&E. Okay, so yeah, we need to make sure that there's no neck injury, okay, with something like that. Perfect. So that's your intro to the atlas and axis, and then this is a little bit more detail with everything else in place as well. Okay, so this is everything together. So we've got notice no spinous process. So saying that on the atlas, on that C1, there's no spinous process. The first spinous process is on the axis. So there's the odontoid peg. You can see the vertebra coming around, forming that spinous process at the back. And then see that bit there? This is the occiput of your skull. And that's where the occiput attaches, right at the top there. Okay, so that's where it rests on the atlas, as I was saying before. So you can see the head balancing on there. There we go. So you can get some nodding actions. This is the atlanto-occipital joint. Get some side bend movements, although that's quite excessive there. But it's rotation is mainly from C1, C2, because you're rotating around that peg. Okay, you can get some side to side movements, but the in the upper cervicals. But yeah, these ones are usually atlas and axis is mainly rotation. And then this is the difference between the other type of vertebra. Okay, let me just go back a sec there. Okay, can you see the different shapes? Yeah, so that's your C1, there's your C2. So they're very different to then these, which are the rest of the cervicals. So the cervical spine vertebra from C3 down to C7, they pretty much all look like this. Okay, so you can still see the vertebral foramen, yeah, either side. We've got the vertebral body this time because there's no body on these. Okay, we've got a dens there, we've got the odontoid there, and that, I guess you could say that that's like an extension of the body, but there's no body here because you need a gap there for the peg to fit in. Yeah, so the shape of them are a bit different at the top to the rest. We've got the spinous process from C2 down to C7, and it's usually what we call bifid, so it's split into two, as you can see there. Okay, not so much on that one. Maybe it's been broken a bit, I don't know, or maybe it didn't develop that way. But you often have a bifid spinous process in the cervical spine. So there's your atlas, there's your axis, which we've already had a look at, and then there's your typical cervical vertebral shape. So vertebral arteries coming through here, spinal cord through here, there's the body. This is the laminar neural arch. Yep, so blood vessels through there, cord through there. There's your spinous process. So it's bifid, as I was saying, so it's split into two. And then we've got these, the transverse process that's then split, and we've got these little projections coming out either side. Articular surfaces, so this is where the other vertebra above and below will attach. And then there'll be a disc as well as we get down to this level. So the joints shape are quite steep, okay? And then there's your intervertebral disc, which again we'll look at when we get to the connective tissue section. So we've got facet joints here, which are different shape to your atlas and axis, yeah? So there's your atlas holding the cranium. No vertebral body because we've got a gap. And then this is all the stuff that we've just had a look at. Worth still going through it again. So yep, the foramen for the odontoid peg, and there's the hole for the spinal cord. I think it's good to see it when you're comparing it against some of the other cervical vertebrae because they are very very different. Yep, so your skull attaching up into there. and we've got that kind of shape which is like a ball, so it's able to move in loads of different directions. And then the axis with the peg, the downward sloping facet joints. There's an odontoid peg fracture. Yeah, so the odontoid peg is the body of the atlas above, but it fuses to the C2. So that's why we have this connection here. And then it allows for that rotation to occur. Cool. And there we go. There it is back on again. And again, we've got a ligament that comes around the back. We've got a ligament that a couple of ligaments that attach onto the odontoid as well to secure it to the skull. Yeah, so ligaments holding everything in place. We'll look at those. And then the peg is attached to the skull as well by something called the alar ligaments, which means wings. Yeah, and we'll have a look at those next week as well. Cool. Okay. Pop that there because we've seen all of that. So that's your upper cervicals. And then we've also had a look at a typical, there we go, a typical lower cervical. So from C3 down to C7. So the body is not present in C1, C2. It's the peg and then the foramen. So it's slightly different. We have got a transverse process, but in the atlas, it's a lot wider, okay? And everything else is narrow. The facet joints are a bit smaller the lower you go down. It's got more to hold. So the cranium's obviously quite wide. There's quite a lot of rotation movement in that atlas and axis. So the facet joints are quite bigger, okay, than these lower or mid and lower cervicals. Right? Cool, good question. So when a client has trouble turning, you're looking at the atlas and axis. Yeah, so what you can do, there's a little test to test the atlas and axis and see if that's functioning okay. You flex the head entirely forward, and then from that fully flexed position, you then try and rotate. And if they're struggling to rotate, then it's coming from the upper cervicals. If they're able to rotate freely through with the neck completely flexed, then it's not the upper cervicals that are a problem, it's the ones below, okay? Or more likely to be, shall we say. Okay, but that's a really nice little test to differentiate between the upper and the lower cervicals in terms of joint restrictions. So just going over that again, you flex your head all the way forward, and then from that flexed position, you then rotate. And if you're stiff in rotation or you feel it reproduces your symptoms, then it is the atlas and axis that is likely to be contributing to that restriction. Because when your neck is fully flexed, you can't get rotation out of any of the other joints, okay, or it's very limited anyway, but you can still get it from the atlas and axis. So that's the test to do. If they're able to move freely on any of those tests, something that you can do, let's say they rotate their head to the right and they're restricted, you get them to shrug their shoulders and then see if they can go any further. Yeah. If they're able to go further with their shoulders shrugged, then it's a muscular issue, more likely to be, because what you've done is you've shortened the muscles, and now if they can rotate, then it must be the muscles that are stopping the rotation. Okay, so much more likely to be. So that's another little test that you can do to check out the differences between the two. Features, like we said before, bifid spinous process. So that's this bit here, the sticking out bit at the back. Transverse foramen, so the hole for the blood supply. Vertebral body in these lower cervicals. Articular facets, which are a bit smaller. Okay, so these here. The pedicle is kind of it's a lot smaller than in the thoracics and the lumbars. Okay, so the pedicle is just here. It's labelled on that side. And then we've got these little tubercles here. So we've got an anterior tubercle and a posterior tubercle. Those will be attachment points for muscles. Okay, and then the lamina, or the neural arch, as it was called as well. So that's this bit just here at the back. So your vertebral foramen is where your spinal cord will go through. Okay, perfect. Let's just have a look, see if we've got any more videos. Yeah, let's have a look at this one. Show you this one. And that would be perfect timing then. So this is inside the atlanto-axial joint and the atlanto-occipital joint. They've chopped through it so you can see the joins. Here we go. So they've taken the back of the vertebra off, so you can see the odontoid peg, you can see the atlas, the attachment onto the skull. So there'll obviously be connective tissue here holding all of this in place. But that's what it looks like without a back on. So like kind of seeing through it. So it's quite useful to be able to visualize that. So you can see the peg. You can see how the atlas wraps around that peg. There's a vertebral, well, kind of the vertebral body extending into the peg. Body of C3, 4. Okay, this is where the skull will attach onto the atlas, just up here. You can see the holes on the side for the blood vessels. There's the joints, facet joints. Okay, again, they're quite big in that area to allow for that rotation. Perfect. Good. Okay, so that is it for the intro to the neck. Next week, we're going to be adding on some of the connective tissues. We'll look at the ligaments that hold those things in place. And yeah, and then once we've done that, we'll then start to add in the muscular layers, tendons, and all that kind of stuff. Okay, cool. I will see you next Monday, 10 o'clock. See you then.